I inherited this talk from Professor Peter Chiodini, for whom, no, not the talk, but the actual title, who could easily have given a talk about the last 40 or indeed 50 years of malaria from personal experience. I, unfortunately, was in short trousers just entering Sacred Heart Primary School in northern Nigeria 40 years ago. So I'm going to talk much more, really, about the last 20, 25 years. And I'm also going to, and this is for the scientists amongst you, I'm going to leave the clever science to Kevin, who follows me, and he is a much more distinguished scientist. I'm going to do some simple, just counting stuff. But I'm going to do that because I think that what's happened to malaria in the UK over the last 20 to 40 years, on the background of what's happened globally, is surprising both in what has happened, but also in many ways surprising in what has not happened. And before I do that, I'd like to thank a very large number of people, only some of whom are listed here, whose data I'm presenting here. I'm obviously, as with all research, only one of an extremely large team. Clearly, imported malaria, which is what I'm talking about here, and this is, I have to say, is the first time I've ever talked about imported malaria. I always usually talk about malaria in Africa or Asia, so this is a novel experience. It remains the most important, potentially fatal imported infection. If you exclude HIV, which arguably is not exactly a tropical disease, it is the most important, certainly parasitic infection. And I think the first thing to say about the malaria, both imported malaria numbers and the malaria deaths in the UK, if you look over the period over which we have good data, which is really the last just over 25 years, is how remarkably stable it is. Think about what's happened in malaria globally. Extraordinary changes in the epidemiology of malaria, where it is, mortality. So, for example, the stunning reduction in child mortality over the last 7 to 15 years in Africa and Asia, halving in many parts of the world in childhood malaria deaths, significant reductions in incidence to a point of almost zero in many areas of the world which previously were malaria endemic, rise in drug resistance, but very many new drugs, insecticide-treated bed nets, better diagnostics. The number of things that have actually changed is very large. And yet, despite that, if you compare 1994, which is the first data which are broadly comparable to the most recent data, roughly 1,900 cases, of which about 1,200 were Falciparum with 11 deaths. The last year for which we have full data, 1,092 Falciparum and 7 deaths. Basically, almost no change at all. I think that's a very striking statistic. It's a sort of classic dog that doesn't bark in the night. Now, the background to this clearly is that malaria has been in full retreat over a very long period. This is malaria in the mid-19th century. And of course, at this stage, it was a significant problem in the USA, right up into Canada, both ends, right up into Europe, into areas we don't think about it. By 1948, after the war, it had shrunk a certain amount. Still a big problem in the USA. There's a reason why CDC is in Atlanta, and that's because that was there to eliminate malaria. And by 1977, which is really sort of close to our 40-year watermark, this is the point which the malaria eradication campaign of that era had got malaria to, plus a certain amount of development. Almost 40 years later, the map of malaria looks virtually identical in terms of the where. Not in the how much, but in terms of the where. And again, I think that's an interesting difference, or lack of difference, over that period. Of course, that doesn't mean that there hasn't been a change in incidence. So in virtually all of the places where the malaria currently exists, the incident rate has gone down either a bit or a lot. But nevertheless, most of the places you could have travelled to 40 years ago and caught malaria, you could travel to and catch malaria now. Now, the rest of the data that I'm going to present are either from the Public Health England Malaria Reference Laboratory, or from the Hospital for Tropical Diseases. A little bit about those data. The main things that I'm going to be talking about is from the UK Public Health England Malaria Reference Laboratory data, which are separate from the notification data, but they're part of the notification system. And the database I'm going to be quoting from is 50,000 cases, probably the largest series of imported infections by some distance, actually, of any country, over a roughly 30-year period. between 1987 and 2013. We've done data using capture-recapture and a variety of other methods that suggest that somewhere between 55 and 65% of all malaria data are captured by this system in the UK. So it's not essentially you have to multiply by a certain factor to talk about the overall data. There's a bias in favour of Falciparum being captured, probably because most of them are admitted to hospital, and there's a bias in favour of London, mainly because Professor Chiodini is quite close and he's very fierce and tends to chase up the places that don't send the data. Now, multiple factors influence imported malaria. These obviously include global incidence. If you don't have malaria in the first place or have very little of it, you're not going to catch it however often you travel. Travel patterns, both country and style of travel, are important, and there have been very significant shifts over the last 40 years in where people who might catch malaria travel to and how they do it, and I'll go into this in more detail in a minute. The third and probably the most important question is where the population who are in the terminology VFR, visiting friends and relatives, usually first, second or occasionally third generation people of African or Asian heritage, could be Latin American but not in the UK generally, where they live and how many of them are and where they go. And clearly prophylaxis and better prevention. The doctors and nurses amongst you do actually do something useful in this area, which I'll come on to. Now, the global malaria incidence, let's start off with the global incidence data, and I've actually, this is stuff which our president has been very heavily influential in setting up and running. This is the MAP project. This is looking at Falciparum incidence in children, simplifying slightly. There are a few things I want to highlight. The biggest one, however, is the huge, relatively high incidence in West Africa. Now, that's very important in the UK and indeed elsewhere in Europe, because where we get malaria is to a very large extent driven by where there are West African diaspora communities. Basically, if you've got a community that comes from the area and therefore goes back to an area where there's very high incidence, you're going to get a lot of imported malaria. If the majority, for example, in France it would be Mali, in the UK, as we'll come on to, it's Ghana and Nigeria in particular. If you've got these large diaspora communities, you're going to get a lot of imported malaria if they come from places where there is a lot of malaria to get. So incidence is important. The second, obviously, is travel. And travel has steadily increased over the 40 years that we're considering. And if you look at this map of travel, what you see is that the UK is right in the middle of the UK transportation, the world transportation system, whether it's by sea, road or air. If you want to get from South Africa to the USA, it's probably through London you're going to travel, leaving aside our own diaspora and travelling community itself. So travel is the second very major driver that explains what happens. Then if we actually look at how malaria has gone, what we find is if you look at Plasmodium falciparum malaria, and the dotted line is a kind of summary measure, Falciparum malaria has actually slowly but steadily increased over the last 20 years, 20 to 30 years. Vivax, on the other hand, has steadily decreased. Although we've done a nice straight line, this increase and decrease have not been linear. But the important graph is this one here. It's the annual passenger numbers. So the reason actually, probably, that we have had remarkably flat malaria in the UK is that two factors are balancing one another. On the one hand, the amount of travel is going up and the number of diaspora communities are going up. And on the other hand, the incidence of malaria globally is going down. And these two have probably kept us in rough balance over quite a reasonable period of time. The third major issue is prophylaxis. Malaria prophylaxis, chemoprophylaxis. Now, those of you who are actually involved in giving chemoprophylaxis in the UK will be well aware of the fact that what is given to people is a combination of hard science, good epidemiology, sensible judgment, and wild hysteria. And which period you're in also varies by time. We're going through a relatively rational period at the moment in terms of malaria chemoprophylaxis. But even so, this is a relatively recent headline, for example, from The Independent, talking about mefloquine, Mariam. Front page, no. Go back 10 years, and there were very many front page stories, particularly in the middlebrow press, saying how dangerous Larium was, and by extension, as far as most travellers are concerned, by how dangerous malaria chemoprophylaxis was, which, whether cause and effect, but I think it probably is, coincided with a significant peak in malaria transmission in the UK. So it's not just what doctors and nurses say people should take. Direct and indirect rumour have a very major part to play in it. What has changed over the last 40 years is a gradual movement from chloroquine, for which there was almost complete sensitivity, actually, in most of the key travelling areas at the beginning of this 40-year period, through down mefloquine, Larium, which has been heavily bedevilled by stories of how dangerous it is. Doxycycline, and it's something we actually we sort of caught as an idea from Australia, where it's been the principal method of prophylaxis for a long time, through to atopic preguanil and Malaria. This change is really almost complete now. A combination of chloroquine resistance and scare stories about mefloquine, plus the fact that atopic preguanil has gone off license, so that the price is now dropping quite rapidly, has meant that the major barrier to people taking this has now essentially become much less. So if people are going to take something, whereas at the beginning of the 40 years it would have been chloroquine, it now is this. And these ones here are really only used in quite specialist cases now. Now, a few trends in terms of the epidemiology. People who are visiting friends and relatives remain the main group. And I think the key point about this is relative to other groups, whether you look at people who do catch malaria or look at people who do not catch malaria, they don't take prophylaxis. So chemoprophylaxis in this group is a very major issue. A few sort of hard numbers. The beginning of the reporting period I was talking about, there were more, the Vivax to Falciparum to Vivax ratio was 1.3 to 1. They were pretty well the same. By the time we get to now, the ratio is about 5 to 1. And although it bounces around, Vivax, as I'll show you, is really significantly down and stayed down for quite a long time. At the same time, the case fatality rate in the UK, so the fatality per case we get, has not changed at all over this period. It's remained virtually identical, despite a lot of trends and fashions in the treatment of severe malaria. Now, there are some reasons why we could explain that, but that's just, as a fact, it's very, very striking. Looking at those who visit friends and relatives, usually in the country of origin, for the UK, 2/3 of all our malaria is in this group, even though it's quite a small group. So if we wanted to reduce malaria incidence in the UK, or malaria coming into the UK, this is the group to concentrate on. And within this, Falciparum malaria, over half of all UK Falciparum malaria comes from just two countries, Ghana and Nigeria, almost exclusively in people visiting friends and relatives. So that small group, who are highly concentrated in London, in fact, as I'll show, is the one to push for. And people who are visiting friends and relatives much less likely to report chemoprophylaxis use. So talking about the migrant populations, here are some of the ones who are very important in terms of total numbers in the UK. So very large South Asian populations, substantial West African populations, and substantial East and Southern African populations. But the group who get malaria are these ones, Nigeria and Ghana. What that means is that where you see malaria is not random in the UK. If you look, this is a map of all migrants in the UK, in England and Wales, and these are everybody who's come from West and Central Africa, and essentially none of them travel outside the M25. That's where they live. If you're talking about the South Asian population, you're obviously talking about a wider spread, but it is still not a random distribution. There are not very many South Asians in Plymouth. Beautiful though Plymouth, I'm told, is. And therefore, what you tend to see in the UK mirrors that. So almost all the Falciparum malaria is concentrated in London. Certainly all the VFR Falciparum malaria is, whereas Vivax tends to follow the pattern where you find South Asian populations. Moving on to some of the severe malaria, clearly, the really major shift in the last 10 years, in the last 40 years, but certainly in the last 10 years, has been the shift from quinine to artesunate as the treatments for severe malaria. This follows two large and extremely important trials, the Sequemat trial of artesunate versus quinine in Southeast Asia, in adults primarily, and the Aquamat trial in children, both of which showed a clear survival advantage for artesunate over quinine. So there has been a very big shift. Has that translated into a major shift in treatment in the UK? And the answer actually is no. Now, there are two reasons for that, one of which is that the drugs, shamefully, given that they've been around for the last 30 years, are not licensed in the UK, nor is there good GMP product. And I have to say, we as a community should feel deeply ashamed of the fact that is still the case. But the second is because of that, there is not, and because of the fact they have a shorter shelf life than quinine, there are not stocks of these drugs in the majority of the hospitals in the UK. So the way we deal with it is we have critical stocks in large central hospitals which see a lot of malaria. The problem with this can be seen if I go through these numbers, and I'm going to go through them quite carefully because I think it shows an important policy point. These are all the UK malaria cases with the size of the circle demonstrating how much malaria there is, with huge preponderance in London, obviously, but a lot outside that. For a system of strategic things, 8 centres have about 45%, 44% of UK cases. 107 hospitals have 10%, and 52% of hospitals seeing malaria see less than 5 cases every 3 years. These people do not stock artesunate. And yet, for reasons I'll come on to, they tend to see more severe disease. Put a different way, centres with less than 10 cases a year treat a quarter of all malaria cases, and a significant number of these are seeing less than 2 cases a year. And if you look at the time it takes to get from diagnosis to treatment, if you're in a specialist centre, you get artesunate within an hour, as you should. If you're in a referring hospital that's part of a hub and spoke system, it'll take you about 7.5 hours. And as soon as you get to a hospital that is actually not a part of that network, you're talking about 25 hours, i.e. more than a day, before you get it. Now, people will be treated with quinine in this, but this is why artesunate is not having its biggest effect then. Now, what exacerbates this is that, by and large, London malaria is dominated by West African malaria, and there is much lower incidence of very severe malaria in these people, because some of them have residual immunity, not necessarily to infection, but to dying. So there's a heavier concentration of severe malaria outside. So in fact, these figures hide a bigger problem underneath them. A few other points which are, I think, sometimes not fully appreciated, and they're easier to see in the kind of populations we see here in the UK. In Africa, age is highly associated with dying from malaria, and it's largely concentrated in children. In the UK, based on very large numbers, work by Anna Checkley and colleagues, Claire Broderick and Baz Nadge and colleagues on Vivax, here's the rate of mortality by age. Very clear trend towards older being a risk. And if you're talking about Vivax deaths, there are no deaths in Vivax patients under the age of 50 in the UK. There were 7 in people over the age of 50, and 4, but that means an almost 1% mortality rate. That's like Falciparum rates in people who are actually 70 years or older. So being old and having malaria is a bad combination. And I think people who are giving prophylactic advice need to take that message, which I don't think fully has been appreciated, on board. Like many conditions, holidays are bad for you. I don't mean holidays for you, I mean holidays and the doctors treating you. There's very clear data that shows that mortality is bigger in weekends and bigger at holiday times. Malaria is no exception to this. So this is the mortality rate by month of the year. The Christmas holiday period is this. Quite striking. The confidence intervals are well away from parity. Experience in managing malaria counts, even in the UK. So this is the mortality rate on a log scale against the number of cases seen by NHS region in the UK. I'm not going to tell you which dot is which. The trend is very obvious, though I would encourage you, if you have malaria, don't go to Newcastle. Interesting, though, in my view, to see this, because if this is going to be made up of two separate parts. One part is that actually places where there's a lot of malaria tend to be where there's a lot of VFR malaria, and it's a combination of they know malaria and they may have a lower incidence of mortality, but that only explains London for the reasons I was showing. The other one, though, is if you only see one case in your career, the probability you're going to get it right first time is going to be lower than if you're actually seeing in your clinical practice 5 or 6 cases a month or more. So I think this should come as no surprise. This is true for every condition in medicine everywhere in the world. But it is, I think people often think, well, malaria is easy, you can just shove in the antimalarials and people will get better. I think we've got pretty clear evidence here. Even in these high intensity environments, that's not true. What kills people, of course, in malaria is primarily delay. Once they've got malaria, the first thing that kills them is getting in the first place, not sleeping under bed nets, not taking prophylaxis, if that's the right thing to do. And if you look at these data, and these are data from Anna Checkley and colleagues, the delay, you see huge delays between an arrival in the UK and symptom onset, not surprising, 5 days, that doesn't matter. And then people who die, a significant delay between symptom onset and getting to hospital. There usually isn't much of a delay when it comes to actually getting treatment. So a lot of the delay is informing people that if they get a fever when they come back, they must go that day, preferably, if not certainly the next day, to go and seek medical care. If they're going to wait 5 days, they're playing Russian roulette, particularly if they're elderly. Just a quick thing on our experience of managing severe malaria here in the UK, because clearly the population group we see here is very different socioeconomically and in many other ways than the population group that look at adult malarias in Asia primarily, and there's relatively little data from Africa. What we find, probably unsurprisingly, is that if you look at severe adult malarias, this is Michael Marks's work, what we find, as with many other centres, but I think it's much more clearly shown in the UK, your big problems with cerebral malaria and kidney disease, acute kidney injury, tend to have presented very early on. Usually if you haven't got them within a couple of days, you're not going to get them. Whereas what used to be called adult respiratory distress syndrome or acute lung injury, ARDS, ALI, they can come on a lot later, including after all parasites have cleared. And what anyone who's managed malaria is aware of is this is a very dangerous syndrome. Within the UK, a mortality rate approaching 50% in good centres. So this is this probably is the biggest group. There should be no deaths from just renal failure in the UK. It's, renal failure and malaria is completely reversible usually, and you can completely get on top of it with hemofiltration or dialysis. Cerebral malaria, in a sense, is a matter of getting on top of early treatment. This is the area where I think there's probably the biggest scope for improving management in severe cases in a high resource setting. Moving on to Vivax malaria, these are data that haven't yet been published. They're all by Claire Broderick and Baz Nadge and others, coming out in the BMJ, I hope, in the next month or two. Just a few headlines, because I think it's really some of them are really striking. The first of which is, I've shown you already, the decrease in numbers of Vivax cases, and the lines here are the number of people travelling to a Vivax endemic country and the number of VFRs travelling to a Vivax endemic country. So clearly that is not what explains it. I had some very excitable correspondence from colleagues who said, well, it's all down to El Nino. So we plotted El Nino, both high and low. Red is high, green is low. I can't see any difference there. I have not yet tried to torture the data, but I don't think I'm going to find anything. I think that this is probably largely down to changes in the pattern of malaria and where people travel to in South Asian countries. But we can't prove it. That's just a hypothesis. What certainly is clear, though, is that if you look at number of Vivax cases in India and Pakistan per 100,000 trips to those countries, it falls off a cliff between about 1996 and 2001, and has stayed off that cliff with a quick blip a couple of years ago since that time. So there's no evidence this is just bouncing around. I think it's pretty clear this change has happened and here to stay. And if you look at the incidence of malaria in those countries, they're continuing to drift down with Vivax and really falling quite fast in most of them when it comes to Falciparum. And what that's meant is that the area where the UK expert committee, the ACMP, is recommending a Vivax prophylaxis has steadily shrunk over the last 10 years. Basically because the risks of taking the drugs are now probably at or even exceeding the risks of actually getting malaria in very large areas. So for India, for example, the areas in red are the only ones where the ACMP now is recommending malaria prophylaxis in the Indian subcontinent. Now, there's an art as well as a science to this. For a long time, Scotland and England had a very different policy about this area of India here, for example. When I'm working for DFID, half of my staff work in Scotland and half of them work in London, so I had a situation where half of them would be given prophylaxis and half would not. We go for exactly the same conference in exactly the same town, which is clearly bizarre. We have tried, particularly since the referendum, to bring our hearts together on this issue. But it is to demonstrate the fact that actually it's not purely science-based. I mean, there's a strong epidemiological basis. Actually, most of the areas in red are places that most people from the UK don't go. There isn't much travel to Assam, for example. So the database is actually pretty thin. A little bit on seasonality, because I think it's really striking, the seasonality. This is just an overall thing about the seasonality of Falciparum malaria, of Vivax, and of other species. And an important point about Falciparum malaria is the seasonality tracks the seasonality of travel, but with a delay, unsurprisingly. But Vivax is more complicated. These are the quarterly passenger numbers per month. This is aggregated data over very many years. Large database, it's about 12,000 cases of Vivax in this study. This is the pattern of malaria you actually see in the UK. And if you then look at latency, that's the time from people touching down in whichever airport they touch down in and getting their Vivax. This is the pattern in people from India and Pakistan. I think that's very interesting. Now, this latency has some important implications, the first of which, in my view, as someone looking at things, if this is replicated in India and Pakistan, and I guess it is, it means, so what you actually, the peak of the monsoon period is here. Now, biologically, what that suggests to me is that actually Vivax essentially is hanging around until actually it can get to the point where there's going to be a lot of rainfall, and then it's coming out. That seems the most likely explanation biologically. There are alternative possibilities. But the other thing it means in control terms is that people who look at the number of Vivax cases will convince themselves that all the problem in Vivax incidence is here and put all their control measures here, and actually the problem is primarily elsewhere. So I think this has got implications for India and Pakistan, and may do for other areas as well, but this is the only countries we've got really clear data from, big enough series, as well as for the UK. And this is the kind of thing you can't see in countries. So it's an example, I think, where endemic, non-endemic data can help inform endemic policy decisions. So a few summary points before we move on to the high science that will be Kevin's talk. Imported Falciparum malaria remains stubbornly high despite substantial global changes in treatment, in prophylaxis, in prevention, and in travel. Cases in the UK are highly concentrated in VFR travellers, particularly West Africans. The mortality is strongly associated with age, but it's old age in the UK, and presenting where malaria is not often seen in terms of the actual physicians seeing them don't often see it. Vivax is now much rarer, and that's probably here to stay, and still a disease of VFR, and there's a marked seasonal latency. And finally, in the UK at least, Vivax deaths are exclusively in the elderly. Thank you very much.